We would like to invite Dr. Anant Yadav, Dr. Ashwin Gadvi, Dr. Tanish Modi, Dr. B.D. Makar sir, Dr. Apurva Parekh, and Dr. Mahadev Bhai. Mahadev Bhai is already there. I would like to request Dr. Mahadev Bhai to kindly introduce the subject and speaker. Dr. Mahadev Bhai.
Yeah, I think we can see that the temperature is already rising, not only outside, but also inside the cardiocon that we could see the last. But I'm sure this is going to be the hottest because the stalwarts coming on the field. And we have Dr. Om Lakhani. He is a consultant endocrinologist at the Zydus Hospital.
Raise your volume, please.
Okay, just a minute. Yeah, before the temperature rises, let's talk something. I'm sure it's going to be a big fight. The very meaning of BOUT will be realized to the audience now that we have got Dr. Om Lakhani, Dr. Sabu, and Dr. Pankaj Agrawal. And the topic is also such, and Dr. Kamal always puts one or two points in such a way that everybody takes advantage of it. And so Dr. Om Lakhani is an endocrinologist at Zydus Hospital. He has his MBBS, MD, and DNB degree, and he is having a President NB Gold Medal in endocrinology. And he has his own notes in endocrinology app, and that's very useful to the practicing physicians. The next speaker is Dr. Pankaj Agrawal. He has his DM endocrinology degree, and he is in Ghaziabad. He's a founder. Medical concepts in Hindi is his main innovations, and he conducts online classes of integrated endocrinology for the postgraduate students in Hindi. He's a principal investigator in 29 global and 5 national studies. He has 26 publications in international and national journals. He is an examiner at the DM endocrinology in the universities. Next is Dr. Bansi Sabu. I'm sure everybody knows him. He's a chief diabetologist and chairman at the Diabetes Care and Hormone Clinic in Ahmedabad. He is an immediate past president of RSSDI. He is president of AIAARO. And if I continue giving his degree, his time will be consumed. So I would better avoid and say he's Dr. Bansi Sabu, and that should be enough. And the topic on which we are going to have the 3 different views are about an elderly gentleman with diabetes, coronary artery disease, CKD, and we have to add the 4th drug in over and above the glargine and the metformin and one of the drugs. So first, Dr. Lakhani is going to talk about the case for liraglutide.
Thank you. Dr. Lakhani may start to his talk. I would like to say a few words regarding this topic. Our topic is titled as CAD, diabetes, CKD, where GLP1a, DPP4 inhibitors or AGI. Out of these 3, which one? The organizers have very intelligently omitted sulfonylureas and glutazones in this discussion. Here, the problem is that he is an elderly man. He is obese. His weight is 90 kg. He is undergone PTCA. He is suffering from CKD and heart failure. With best medicine so far he is on SGLT2 inhibitors, metformin and glargine, and diet and lifestyle modifications, his diabetes is not under control. So our main discussion today will be regarding how to control his diabetes well as far as his fasting, PPBS and HbA1c are concerned. Because by controlling his diabetes, we can have some better outcome. In this patient being elderly, there may be other coexisting comorbidities.
We will have a discussion at last.
Just few
10
words.
minutes. So you can always give
because these things are to be kept in mind while dealing and discussing this type of case. He might have cognitive dysfunction, he might have gastroenteropathy, he might have prostate problem, he might have osteoporosis and other things. So I request the speakers to consider all these points if they have time. So
very valid points.
The discussion can be handled nicely.
We agree,
so please,
sir.
I also welcome all the chairpersons and co-chairmen, co-moderators. Please start the discussion.
Thank you, sir, for the kind introduction, and thank you to Dr. Jayesh Trivedi, sir, Dr. Madhav Desai, sir, Dr. Kamal Sharma, sir, for this. Can I be allowed to share my slide, please? Yeah. Thank you. Yeah, are my slides seen?
Yeah.
Yeah, okay, thank you. So, I think the case is already been introduced to the, to the audience. And I'm going to talk about the GLP-1 receptor agonist. This is the financial disclosure. And I'm going to talk from the perspective of GLP-1 receptor agonist as the, the next choice for this patient. But, as all of you, and a lot of you would have seen the movie Three Idiots, these three guys who end up in a marriage and then they are told that आप कौन से side से हैं, आप bride के side से हैं कि bridegroom के side से हैं, तो they say हम science के side से हैं. So I think same here. I'm neither from GLP side nor DPP side or AGI side. I'm actually trying to be more neutral and from science side. I think so. That is what my focus will be. So we have this patient who has already been introduced. Like I said, 72-year-old, 90 kg weight. Its eGFR is 39, HbA1c is 8.9, its fasting is 212, postprandial 276, and LVEF is 48%. So this is the history with the past history of PTCA. Now let's dissect this case further. So what are the issues that we have in this patient? So naturally the patient has a poor glycemic control, but I'd like to see the data more closely. And I often see the delta value. So delta value is basically the postprandial sugar minus the fasting sugar, which is 64 over here. But his fasting is 212. So keep this in mind. I'll come back to this. Remember, my science ke taraf se, right? Okay. The patient has an increased creatinine. Now, see, we have been told that the patient has CKD, but we don't know the baseline creatinine of this patient, right? We don't know the past history. We just know the current situation, right? And that is what happens in a lot of our practice. We don't know the etiology for the increased creatinine. We have the patient having AHCVD. He's having heart failure with reduced ejection fraction. Slightly reduced ejection fraction, and he's having ongoing medicines which are basal insulin, metformin with an SGLT2 inhibitor. Now, these are the options which are given to us. Add a GLP-1 receptor agonist, either an oral semaglutide or a liraglutide. Add a DPP4 inhibitor. Add an AGI. Add a maglitinide, which is Dr. Banshi Sabu is going to speak on this, and others. So, what is your answer? Well, allow you to think about it. We'll come back to this in a discussion. But my answer, so I said in the beginning, I was to talk on GLP-1 receptor agonist, but my answer is none of the above. I'm not going to add this patient on a DPP4, a GLP, a AGI, a maglitinide. No, I'm not going to do any of this. All I'm going to do in this patient is to fix the fasting first. I think that is the message which should be going today, right? The answer, in my opinion, and science ki taraf se, the answer is E, none of the above. The patient does not need any of these medication. All the patient needs here is to correct the basal insulin dose titration, right? That is all we need to do. Remember, no matter what the dose the patient is taking, right? There is a lot of wrong concepts about basal insulin. We don't know what dose this patient is taking, but whatever the dose is taking, the best thing about insulin is that you can always give more, right? So you can easily give this patient more basal insulin, titrate the basal insulin correctly. There is no upper limit of what basal insulin you can give. Remember, basal insulin is going to be the safest drug as well, right? Because the patient has CKD. There are very few contraindications to use of basal insulin. This patient is already on basal insulin. All we need to do is titrate the basal insulin correctly. That is all we need to do, right? No other fancy medicines are required here, right? That is the science ki taraf se answer, right? So no new medicines. We see this type of patients very commonly in our practice. All you need to do is, first of all, review the patient's basal insulin technique and teach the correct technique. Every single day, I see patients with high doses of insulin, multiple doses of insulin, sugars are not under control, and you see this patient is having big lipohypertrophies on their abdomen, right? Patient is taking injection at the same site every day, right? Initially, the sugar was controlled for a few days. After that, the sugars are not under control. Half of the patients are not aware that they are supposed to change their pen needle. They don't know how frequently to change their pen needle. They don't know the correct technique for insulin injection. That's the most important thing. That is what we should be doing, right? So teach the patient the correct technique, check the patient's technique and teach the patient the right technique. Increase the dose of basal insulin. Ask the patient to report the fasting sugar daily by whatever means. Target to fix the fasting, target a range of 90 to 130. And like Sir said, it's an elderly gentleman. Let's keep it 100, right? Keep it 100 to 130. What this will do is, remember the delta gap. Delta gap was 64. If I just bring the fasting down to, let's say, 100, right? 100 plus 64 is 164. The patient's postprandial will also come down to less than 180, right? And if you do the HbA1c after 3 months, patient's HbA1c will be easily less than 7, right? So remember the most important thing, right? In any patient, always, especially patients with high HbA1c, whenever you have higher HbA1c, the contribution of the fasting sugar is higher to the overall HbA1c. And hence, in all these patients, the important thing is to fix the fasting first, right? And in this patient, the fasting itself is 212. You don't need to do anything, just fix the fasting first. And we need basically, right, an agent which improves the fasting. And in this case, the patient is already on the best agent which can control the fasting, that is basal insulin, right? But we are, have to play the devil's advocate, right? I think this is I would say the correct answer, but we have to choose one of the drugs as we have been told, right? And in that scenario, right, let us look at the other options, right? So your GLP1, your DPP4, AGI, meglitinide. Well, answer 2, 3, and 4 are all wrong answers, because remember, we need a drug which corrects the fasting. And amongst all these 4 options, the only drug which has predominantly good action, or not say predominantly, I'll say good action on fasting is GLP1 receptor agonist. That is a long-acting GLP1, right? So we need a long-acting GLP1, something like either a liraglutide or an oral semaglutide, which can have action on the fasting blood sugar. DPP4 mainly has action on postprandial. AGI only has action on postprandial. Meglitinide has only action on postprandial. Patient's fasting is 212. उसके postprandial is 264. उसको postprandial को और कम करके क्या करोगे? Right? कुछ नहीं करना है. Postprandial को नहीं touch करना है. Just correct the fasting. Right? So I don't know what Dr. Banshi sir is going to argue or what Dr. Agrawal is going to argue, but the simple point is, इसमें postprandial control करके there is nothing we are going to gain out of it. Right? So of all the options which are available, the only viable option, right? Forget cardiovascular risk, forget CKD, everything. The only viable option is to either increase the basal insulin dose or to add a GLP1 receptor agonist. These are the only options that we have, right? Now, the other big question here is the patient's, should the metformin be continued? Now, this is an important question, right? This patient's eGFR is 39. The patient is already on metformin, right? So what do? Should you continue metformin or should you discontinue metformin? That is an important question, right? So this is the guidelines from Korean Diabetes Society. Similar guidelines are followed all across the world, right? I chose the Korean one because it's the most well written, right? Remember, it is said that metformin can be used in full therapeutic doses when the eGFR is more than 45, right? If the patient is already on metformin and the eGFR is between 30 to 45, then you can continue metformin, but the dose should be less than 1 gram. And if the patient's eGFR is less than 30, then you do not initiate metformin, right? So that's the broad guideline. So in this case, we don't know the dose of the metformin the patient is taking, but the patient's eGFR is 39. That means up to 1 gram of metformin we can safely give to this patient. So metformin, I will continue. If the patient's dose is more than 1 gram, I'll reduce it to 1 gram, but I will continue the metformin in this patient. Second important question, and Dr. Kamal Sharma sir is like a mentor and teacher to me, right? I've learned a lot from his book, and I knew that if this question is asked, there will be a SGLT2 there, right? I'm sure he's a big proponent of this very good molecule, right? Should you continue SGLT2 inhibitor in this? That's also important, right? So in this case, now we know that the patient has CKD, but we don't know whether this is acute on chronic or this is just a chronic kidney disease. We don't know the prior creatinine of this patient. So we are assuming that the patient is having CKD, right? We are assuming that the patient's creatinine has been stable, right? But what do you do if it was not, right? So if you see the KDIGO guideline about CKD, the KDIGO guideline says, again, we talked about metformin already, but about SGLT2 inhibitor, it says that if the eGFR is less than 30, do not initiate SGLT2. If the patient is on dialysis, discontinue SGLT2. But in other conditions, you can either continue SGLT2 or add SGLT2. In this case, patient is already on SGLT2 inhibitor, so you can continue that, right? And added to that, the other options you have are GLP, DPP4, insulin, AGI, and so on, right? But if you see the guidelines very clearly, it says the preferred drug is GLP1 receptor agonist. So again, right, I may say anything, but the guidelines clearly say that the next preferred drug in this patient should be a GLP1 receptor agonist, which of course, is the thing, right? And again, In simple terms, any patient with SGLT2, with CKD, remember if eGFR is more than 30, you can give, right, at any level of hyperglycemia. So you can give SGLT2 in this patient or continue SGLT2 in this case. When do you discontinue? Now what happens is if you add an SGLT2 inhibitor and there's an acute drop of eGFR, which is often hemodynamic in origin. If this drop is more than 30%, you discontinue the SGLT2 and reassess the patient. But if the drop is less than 10%, you can continue using the drug. So in this patient, you review the patient's past eGFR values. If you have that value, assess whether there is a recent drop in eGFR. If there is no recent drop in eGFR, you can continue your SGLT2. If the recent drop in eGFR is more than 30%, you need to discontinue SGLT2.
Last 1 minute.
Yes, sir. Okay, sir. What is the so with conclusion with SGLT2, you can continue SGLT2 in this patient. Now, coming to GLP1 receptor agonist, right? We need to consider two things here. First thing, can the patient afford a GLP1? Second is, can the patient tolerate it, right? Any patient you start a patient on GLP, these two considerations should be there. Assuming that both these considerations are there, the arguments in favor of GLP are, you have good glycemic control, it helps in weight loss, it prevents CKD progression, and most importantly, prevents future cardiovascular events, right? If you see overall in terms of, the weight loss of oral semaglutide is definitely more sharper than sitagliptin, right? You can clearly see from this data, right? And again, if you talk about cardiovascular benefit here, remember this patient has ASCVD, patient has atherosclerotic cardiovascular disease, and the drug, which is the best drug for preventing the progression of atherosclerotic cardiovascular disease, as we have seen from data earlier, is a GLP1 receptor agonist, particularly in this patient, a Victoza or a liraglutide, right? Oral semaglutide, unfortunately, does not have cardiovascular benefit data, we have cardiovascular safety data, right? So this is the point here. HbA1c reduction is also the sharpest, again, with oral semaglutide, and most importantly, oral semaglutide can be given at any eGFR value. You can give it to any patient irrespective of the eGFR, and it can be easily given, and it is completely safe, right? So you can give it at varying degrees of renal impairment, and no dose adjustment is required. In fact, it is effective in patients with higher grades of CKD also, and it prevents the renal deterioration also, right? So again, we are all aware about the cardiovascular benefits of GLP1 receptor agonist. And I think, I'm sure Dr. Banshi Sabu and Dr. Pankaj Agrawal sir will also agree with me that if cost is not an issue, then GLP1 receptor agonist would be a great choice for this patient, right? So again, these are the other things. We'll not go into details about how, GLP1 receptor agonist protects the cardiovascular system. You are all aware of this, right? But let us look at GLP1 from a perspective of this being an ideal agent, right? It reduces HbA1c, fasting, and postprandial. It will produce minimum hypoglycemia. It will reduce the weight. It will have cardiovascular benefits, especially atherosclerotic cardiovascular benefits. Generally, side effects profiles are tolerable except for GI side effects. No dose requirement is required in old age, and no dose modification is required in this CKD situation. So there's no doubt about it that GLP is an ideal drug. The only factor is the cost here, right? That is the only factor in mind, right? So just to summarize, in this patient, remember, like I said, मैं science की तरफ से हूँ, ना मैं bride की तरफ से, ना bride groom की तरफ से. In this case, the best idea is to fix the fasting first. All the patient needs basically is proper basal insulin dose titration. The metformin can be given up to 1 gram in patients with eGFR between 30 to 45. SGLT2 may be continued. Of course, the benefit is definitely more than the risk in this patient and can be continued. GLP1 receptor agonist is a great choice, provided the patient, two things. Patient can afford it and patient can tolerate it. If both these things are taken into consideration, GLP is a great choice for this patient. In obese patient, GLP provides additional benefit of weight loss. And remember, in terms of atherosclerosis, GLP1 receptor agonist is the best agent for the atherosclerotic prevention. And remember, in this patient, a combination of GLP1 with an SGLT2 from a cardiovascular point of view will be, as a lot of us would say, and as Dr. Pankaj Agrawal would say in Hindi, "Sone pe suhaga." Right?
Very well taken. You did very well. It's a very big topic, but you summarized so well. Now we'll go to Dr. Pankaj Agrawal. You will remain with us during the discussion, please.
I think Om also spoke for others. I mean, he was covering others' topic as well.
Yes.
He has made things clear for everyone now.
Yes, sir.
Dr. Pankaj Agrawal.
Yeah, धन्यवाद. धन्यवाद डॉक्टर कमल शर्मा, धन्यवाद डॉक्टर जयेश. और जैसा कि डॉक्टर ओम लखानी ने, मेरे मित्र ने बहुत अच्छा स्टेज सेट कर दिया है. और एक फेमस सेइंग है, रास्ते अभी और भी हैं. तो किसी भी एक रास्ते को पकड़ के जिद उस पर करना बहुत अच्छा भी नहीं है। हमें मालूम है हार्ट फेलियर के ट्रीटमेंट के लिए बहुत सारे ओरल एजेंट्स हैं। जॉब मुझे दिया गया है वो DPP4 इनहिबिटर्स को डिस्कस करने का। तो DPP4 इनहिबिटर्स आर सेफर, ओरल, इनएक्सपेंसिव एंड बेटर ऑल्टरनेटिव्स। इसको डिस्कस करना चाहेंगे हम अगले कुछ मिनटों में। और जो हमारा मिशन है, मुझे आशा है कि आपको यह पसंद आएगा यदि हम अपनी इन्हीं डिस्कशंस को अपनी मातृभाषा हिंदी में करें। दो प्रश्न यहाँ आते हैं इस पेशेंट को देखते हुए। पहला, एक जनरलाइज्ड क्वेश्चन कि क्या हार्ट फेल्योर में DPP4 इनहिबिटर्स सेफ हैं। दूसरा, इस पर्टिकुलर केस में यदि हम DPP4 इनहिबिटर्स जोड़ें तो क्या वह फ्रूटफुल होगा, इसके लिए लाभकारी होगा। आइए इनको एक एक करके हम लोग डिस्कस करते हैं। DPP4 इनहिबिटर्स हार्ट पर, स्पेशली हार्ट फेल्योर में, जो दो तरह से काम करते हैं, एज ए पार्ट ऑफ GLP1 एंड एज एन इंडिपेंडेंट एजेंट। डॉक्टर ओम लखानी ने बहुत अच्छा GLP1 एनालॉग्स के ऊपर बोला, बताया, और मैं उनसे पूरी तरह से सहमत हूं कि हमें साइंस की तरफ से होना है, ना कि किसी एक एजेंट की तरफ से। DPP4 इनहिबिटर्स क्या है? GLP1 एनालॉग्स और DPP4 इनहिबिटर्स एक ही थैली के चट्टे बट्टे। DPP4 इनहिबिटर्स फिजियोलॉजिकल मैनर में काम करते हैं, फिजियोलॉजिकल लेवल्स ऑफ GLP1 को बढ़ाते हैं, और इसलिए उनकी लिमिटेड कैपेसिटी है। मैं इनको कहता हूं सल्फोनिलयूरियाज। और GLP1 एनालॉग्स वो एक्सोजिनसली दिए गए GLP1 एनालॉग्स हैं जो कि फार्माकोलॉजिकल कंसंट्रेशंस में GLP1 को बढ़ाते हैं, और इसलिए इनकी पोटेंसी DPP4 इनहिबिटर से बहुत ज्यादा होती है। इट्स जस्ट लाइक इंसुलिन। तो सल्फोनिलयूरिया से हम थोड़ा इफेक्ट अचीव करते हैं, इंसुलिन से हम, जैसा कि डॉक्टर ओम ने कहा, अनलिमिटेड। उसी तरह से DPP4 इनहिबिटर से हम थोड़ा एफिकेसी हम ले सकते हैं, और GLP1 एनालॉग से उसकी अपेक्षाकृत बहुत ज्यादा। लेकिन जो फार्माकोलॉजिकल कंसंट्रेशंस में जो इफेक्ट है, जो एडवांटेजेस बताए ओम ने, वह DPP4 इनहिबिटर से हमें नहीं मिलते। DPP4 इनहिबिटर्स के अपने इंडिपेंडेंट एक्शंस भी हैं। नाइट्रिक ऑक्साइड प्रोडक्शन बढ़ाता है, थोड़ा एंटी इन्फ्लेमेटरी रोल है इसका इंडिपेंडेंटली, और बहुत महत्वपूर्ण है कि BNP की मेटाबॉलिज्म में DPP4 BNP को भी मेटाबोलाइज करता है, जो DPP4 इनहिबिटर उसको कम करके BNP लेवल्स बढ़ा सकता है, और इस तरह से फ्रूटफुल हो सकता है। लेकिन यह जो पैथोफिजियोलॉजिकल मैकेनिज्म इसके लिए सजेस्ट की गई है, यह स्टडीज में बहुत अच्छे से अभी तक प्रूव नहीं हुई है। तो इतने एडवांटेजेस होने के बाद भी कंट्रोवर्सी क्या है? कंट्रोवर्सी शुरू तो हुई थी 2013 में सेवर्टी में ट्रायल, जो सेक्साग्लिप्टिन का ट्रायल था, जिसमें देखा गया कि हार्ट फेल्योर की इंसिडेंस 27% बढ़ गई, 1.27 हार्ट हैजार्ड रेशियो। इसी के बाद यह रिकमेंडेशंस आनी शुरू हुई कि नंबर 1 DPP4 इनहिबिटर्स हार्ट फेल्योर या हार्ट में कोई बेनिफिशियल रिस्पॉन्स तो देते नहीं, स्पेशली सेक्साग्लिप्टिन हमें ऐसे केसेस में अवॉइड करना चाहिए, और जो कि हम आज तक मानते चले आ रहे हैं। मैकेनिज्म क्या हो सकता है? शायद जो सिंपैथेटिक ओवर एक्टिवेशन, उससे इंड्यूस्ड कार्डियोमायोसाइट्स की अपोप्टोसिस, और शायद कुछ और पैथोफिजियोलॉजिकल मैकेनिज्म में जिनके द्वारा ये हार्ट फेल्योर जनरेट करते हैं। लेकिन 2013 से अभी तक बहुत बहुत लंबा सफर तय हो चुका। कई और स्टडीज में यह डाटा कभी आज तक रेसिप्रोकेट नहीं हो पाया। सेक्साग्लिप्टिन दोबारा किसी भी ऑब्जर्वेशनल स्टडी में उसने यह नहीं शो किया, यह नहीं प्रूव हुआ कि उससे हार्ट फेल्योर की प्रेवलेंस, इंसिडेंस बढ़ती है। आप ये देखें, 2 लाख पेशेंट्स में भी सेक्साग्लिप्टिन का हॉस्पिटलाइजेशन फॉर हार्ट फेल्योर उसके बाद दोबारा नहीं देखा गया। सिटाग्लिप्टिन 1 लाख एंड अबव पेशेंट्स में नहीं देखा गया। और जब डिफरेंट स्टडीज में और बड़े बड़े डाटा पर ये चीज ट्राई हुई, तो देखा गया सिटाग्लिप्टिन वर्सेस सेक्साग्लिप्टिन कोई डिफरेंस नहीं है, और सल्फोनिलयूरियाज के साथ भी बहुत कोई डिफरेंस नहीं है। तो सुर बदलने लगे। 2013 से 2018 आते आते क्या कहा जाने लगा कि देयर इज नो स्टैटिस्टिकल इंक्रीज रिस्क विद DPP4 इनहिबिटर्स इन रिस्क फॉर हार्ट फेल्योर। तो सेक्साग्लिप्टिन लेकिन अभी एक बार बदनाम हो चुकी, तो क्या किया जाए? उसको हम अभी भी एक अलग कैटेगरी में रखते हैं। लेकिन बाकी DPP4 इनहिबिटर्स का जो ऑनगोइंग जितने भी क्लिनिकल ट्रायल्स हुए, उनमें देखा जा रहा है किसी से और हार्ट फेल्योर के हॉस्पिटलाइजेशन का रिस्क नहीं बढ़ता। तो आज की स्थिति क्या है? आज का जो करंट लास्ट ईयर रिकमेंडेशंस है वो ये है कि डेफिनेटली इनसे सीवी बेनिफिट तो हमको नहीं मिलता, लेकिन दीज आर नॉट बैड एजेंट्स। तो थर्ड फोर्थ लाइन एजेंट के तौर पे आफ्टर SGLT2 इनहिबिटर्स, आफ्टर GLP1 एनालॉग विच आर द प्रूवन ड्रग्स, उनके बाद मेटफॉर्मिन के बाद एज थर्ड और एज फोर्थ लाइन एजेंट हम DPP4 इनहिबिटर्स को यूज कर सकते हैं। अगर किस कार्डियोलॉजिस्ट के बीच में मैं इसको कहूं DPP4 इनहिबिटर्स को, तो मैं जो डिस्कशन अभी डॉक्टर अभिषेक के साथ हो रहा था, मैं कहूंगा कि DPP4 आर जस्ट लाइक एम्लोडिपिन। जैसे ये एम्लोडिपिन आप कहीं भी दे देते हैं और उसका कार्डियक पेशेंट, रीनल पेशेंट में बहुत ज्यादा डिफरेंस नहीं होता माइनर चेंजेस को छोड़ के, वैसे ही DPP4 इनहिबिटर्स हम लोग बेहिचक इस्तेमाल करते हैं, उसका कहीं पे बहुत मेजर डिफरेंस नहीं आता। और मैं इसको इसीलिए कहता हूँ ये तो आलू है, किसी भी सब्जी में डाल दो उसके साथ में चल जाएगा। तो अगला क्वेश्चन आता है, इस हमारे पर्टिकुलर केस में DPP4 इनहिबिटर्स की क्या पोजीशनिंग होनी चाहिए? हमारा प्रोफाइल अभी ओम ने अच्छे से डिस्कस कर ही चुके हैं, आइए एक एक करके हम इनकी पहलुओं को समझते हैं। ओल्ड पेशेंट DPP4 इनहिबिटर्स बहुत सुरक्षित हैं और बहुत इफेक्टिव हैं, देयर इज नो डाउट। ओबेसिटी के साथ दे आर न्यूट्रल, इनसे वेट गेन भी नहीं होता, वेट लॉस भी नहीं होता। अगर ओबेसिटी को ध्यान में रखना हो तो डेफिनेटली SGLT2 इनहिबिटर और GLP1 एनालॉग एक बेहतर चॉइस होंगे। पोस्ट PTCA पेशेंट में डेफिनेटली ये न्यूट्रल है, इनसे कोई ना बेनिफिशियल रिस्पॉन्स है ना इनका कोई डिलीटेरियस रिस्पॉन्स है, और यहाँ पर भी SGLT2 इनहिबिटर्स और GLP1 एनालॉग्स बेटर होंगे। मैं इसके लिए डॉक्टर ओम को और उनकी प्रेजेंटेशन को यहाँ पे प्रेफर करूंगा और कोट करूंगा। इजेक्शन फ्रैक्शन 48% कॉम्प्रोमाइज्ड है। यह वो जगह है जिसके कारण से अभी तक DPP4 इनहिबिटर्स जो डिस्प्यूटेड है, तो या तो वो न्यूट्रल है या सेक्साग्लिप्टिन के साथ देखा गया इट इज हजार्डस। और डाटा हमारे पास क्लियर कट है कि SGLT2 इनहिबिटर्स दे आर प्रेफरेबल एजेंट्स फॉर दिस ग्रुप ऑफ पेशेंट, तो उसको हमें प्रेफर करना है, वो हमारे पास ऑलरेडी चल रहा है। eGFR कॉम्प्रोमाइज्ड है, यहां पर DPP4 इनहिबिटर्स की क्या पोजीशनिंग होनी चाहिए? कॉम्प्रोमाइज्ड eGFR के साथ में DPP4 इनहिबिटर्स दिए जा सकते हैं, सुरक्षित हैं और इफेक्टिव हैं। अंतर क्या है? कुछ एजेंट्स जिनका डुअल मोड ऑफ एक्सक्रीशन है लाइक लेनाग्लिप्टिन, टेनेलिग्लिप्टिन, वह विदाउट डोज एडजस्टमेंट दिए जा सकते हैं, और बाकी सेटाग्लिप्टिन, विल्डाग्लिप्टिन, एलोग्लिप्टिन यह सब डोज एडजस्टमेंट के साथ दिए जा सकते हैं, लेकिन ये इफेक्टिव हैं और इनके कोई डिलीटेरियस रिस्पॉन्सेज नहीं दिखेगा। जो लास्ट और जो डायबिटोलॉजिस्ट के लिए सबसे महत्वपूर्ण जो पहलू आता है वो है HbA1c 8.9%। सारे DPP4 इनहिबिटर्स अमूमन 1% HbA1c को रिड्यूस करते हैं, और यहाँ पे ओम ने बहुत अच्छे से डिस्कस किया इस पहलू को कि अगर हम 7% का टारगेट भी ले तब भी 1.9% का एलिवेशन है, और 1.9% का एलिवेशन हम केवल DPP4 इनहिबिटर से नहीं ले सकते। तो यहाँ पे अगर हम DPP4 पे ही भरोसा करके चलेंगे तो यह राह हमारी मुश्किल हो जाएगी, हमें किसी और का सहारा लेना पड़ेगा। लेकिन 1% HbA1c रिडक्शन से भी आप जानते हैं, मुझसे बेहतर जानते हैं कि 15% रिस्क हमारा हार्ट फेलियर का कम होता है, तो यह बहुत अच्छे एजेंट रहेंगे। फिर से जिस पहलू को हमने बहुत अच्छे से डिस्कस किया, मैं तारीफ करूंगा कि 212 to 76 जो डेल्टा फिगर जिस पे अभी लोग बहुत कम ध्यान देते हैं, वह उन्होंने पॉइंट उठाया। यहाँ पर 212 फास्टिंग एक बड़ा डिनोमिनेटर है और सिग्निफिकेंटली हाई HbA1c। तो मेटफॉर्मिन तो हमें चलाते रहना है, जिसकी के ऊपर डिस्कस हो चुका है कि eGFR के अकॉर्डिंग उसकी डोज डिसाइड करें। SGLT2 इनहिबिटर्स चलाते रहना है, पुनः इस बात को देखते हुए कि बहुत सीवियर कॉम्प्रोमाइज ना हो। यहाँ पर 38 है, कोई दिक्कत की बात नहीं। ग्लार्जीन हमें बढ़ानी है जब तक कि फास्टिंग हमारा नियर नॉर्मल लेवल पे ना आ जाए। DPP4 इनहिबिटर्स अगर हम जोड़ ही रहे हैं तो हमें वह DPP4 इनहिबिटर प्रेफर करना है जिसका कि बाई मोडल एक्सक्रीशन पैटर्न हो, लिनाग्लिप्टिन या टेनेलिग्लिप्टिन, जो हम फुल डोजेस में यहाँ पे फुल एफिकेसी के साथ इस्तेमाल कर सकें। और केवल ग्लार्जीन को देते हुए यदि हम पीपी को कंट्रोल नहीं कर पाते हैं, हालांकि ग्लार्जीन और DPP4 इनहिबिटर के बाद कोई पहलू अनटच्ड नहीं रहना चाहिए। लेकिन अगर फिर भी आफ्टर ब्रेकफास्ट कंट्रोल हो गई, हमने देखा आफ्टर लंच बढ़ी हुई है, आफ्टर लंच कंट्रोल हो गई, आफ्टर डिनर बढ़ी हुई है, तो करस्पॉन्डिंग मील के पहले हम एक प्रेंडियल इंसुलिन जोड़ सकते हैं। तो डेफिनेटली इस प्रकार के पेशेंट्स में हम DPP4 इनहिबिटर जोड़ तो सकते हैं, लेकिन यहाँ पे इस गिवन केस में ग्लार्जिन को बढ़ाना सबसे पहला पहलू होना चाहिए। DPP4 इनहिबिटर्स को हम उसके साथ जोड़ सकते हैं, जैसा कि बात हुई कि GLP1 एनालॉग होते तो बेहतर होता। तो मैं यहाँ पे विदाउट एनी आर्गुमेंट मैं सरेंडर कर रहा हूँ, मैं कोट कर रहा हूँ उनको कि GLP1 एनालॉग्स अगर होते तो यहाँ पर बेटर होते, DPP4 इनहिबिटर न्यूट्रल ही रहेंगे। और AGI मैग्नेटाइट के बारे में अभी आना है और बंसी बात करेंगे उसके विषय में। DPP4 इनहिबिटर्स डेफिनेटली सेफर एजेंट्स हैं इस तरह के पेशेंट्स में भी, ओरल और इनएक्सपेंसिव आज 2022 में तो है ही, लेकिन मैं बेटर कहने से पहले बचना चाहूंगा। बेटर एजेंट्स नहीं है, बट दीज एजेंट्स कैन बी यूज्ड इन सच टाइप ऑफ पेशेंट्स। धन्यवाद। मैं समझता हूँ चेयरपर्सन मैंने अपने टाइम के अंदर ही खत्म किया और डिस्कशन के लिए मैं उपलब्ध रहूंगा। धन्यवाद
सर। टाइम से खत्म करने के लिए आपका धन्यवाद। We will go to the next speaker. He is our Bansi Sabu. Dr. Bansi.
Yes, I am there, Dr. Jesh Bhai.
You are always ready. I know that.
Yes. First of all, thanks Kamal for giving me an opportunity. Om was talking for first 5 minutes that case is wrong. I agree that the fasting sugar was not controlled, and let us assume that glargine is given in full dose, and let us consider that fasting sugar is 112. And Kamal and Dr. Apurva had referred the patient for control of the sugar with 8.9 A1C. So now understand that this patient is already on insulin, full dose, and he's having fasting sugar of 112 with 276. Already Dr. Pankaj has talked about the DPP4, but he agreed that GLP1 is the best, and that as far as science is concerned, we agree and we will go with the guidelines also. But where I will place that, should I put the patients on a glinides or on alpha glucosidase inhibitor in combination? Because patient has been referred from cardiologist and nephrologist for a good control of diabetes with 8.9 is not acceptable. Even the patient may be a 72-year-old guy, or he is having a patient with a post PTCA or his LV dysfunction. So this is the case. We all know now. I did not need to discuss more about it. So the guideline approach, fully I agree that this patient should have achieved the A1C of around 7.5. And there should not be further weight increase, which GLP1 will be best. Cardiorenal prospective anti-diabetic agents, if patient is already on SGLT2 inhibitor, we would like to put the patients on GLP1, and glargine will take care of the fasting sugar. But in real world, it does not work. And that is what, even after next 5 minutes, again, we could not convince that patient should be started on GLP1 or not. Are we adherent to the guidelines, which is recommended therapy? And this is the data which is published in 2019. And even from the Western world, where these molecules are available to the patients free of charge, and still the clinicians are not writing the way they should write, or the guideline-based therapy. Here you can see less than 10% of the patients with type 2 diabetes with cardiovascular disease received guideline recommended therapy for CV risk reduction, even in developed world. And this is the data which I am showing, which is published in 2019. Now, attaining A1C for these patients, I am sure all of you will agree that patients should achieve a A1C of less than 7.5. If not very good tight control, we don't want hypoglycemia, but definitely HbA1c should be around 7.5. Hyperglycemia itself leads to a lot of problem, even in a person who is not having cardiovascular disease or somebody who is having already cardiovascular disease, because PPSG is a postprandial hyperglycemia associated with hypercoagulability, including increasing platelet activity and activating platelets. And there are multiple other reasons for which postprandial hyperglycemia has to be controlled, not only just for getting A1C to get control. If I just put the list of all the anti-diabetic agents which are available to us, and this patient is already on SGLT2 and metformin. Can we give the patient sulfonylurea? Risk of hypo is more. Glitazone may precipitate heart failure. SGLT2 patient is already there. GLP1, yes, it's a choice of drug, but the GI issue, the cost, pancreatitis, needle prick, even though now it is available in oral form, but the cost is a major challenge. Alpha glucosidase inhibitor safely can be given with eGFR up to 25. This patient is having 39. The glinides can be given even in the patient with CKD and end-stage renal disease. You can give up to 0.5. 0.5 can be given further broken in half tablet as per the dose, as patient should not develop the hypoglycemia, and at the same time post-meal glucose has to be controlled. Now this is the data, I'm sure all of you agree, and you know it also that which anti-diabetic therapy can be given in different stages of CKD, and it is the glinides which can be given in the patient even his eGFR is less than 25. Even we can give it even in end-stage renal disease where the eGFR is even less than 15 also. So this is safely can be given in the patient with CKD, and this patient is having a progressing chronic kidney failure. Now, as far as efficacy is concerned, now this patient is 8.9, considering the fasting sugar is 112 and glargine dose is full given, still the A1C is not getting control. Now, what molecule would you like to give? You have a choice of GLP1 and DPP4 with the average A1C reduction is a third line agent will be 0.5 to 1.1. And you can see here with the sulfonylurea, glinides and alpha glucosidase inhibitor, they are highly efficacious drug because now this patient's major concern is a postprandial hyperglycemia. If I can achieve the glycemic control or the post-meal glucose level from 250 to 150, the A1C reduction will be almost in the tune of 1.5 or 1.3, and that you can achieve only by AGI or glinides or a short-acting sulfonylurea, which will not be possible with DPP4 and GLP1 analog. And that's the reason the patient can be, for a good glycemic control, the glinides and alpha glucosidase inhibitor can be a choice of therapy. Is postprandial glycemia harmful? We all know it. International Diabetic Federation had come out with a special booklet which is talking about the post-meal hyperglycemia is a harmful and it should be addressed. And what they are talking, the several class of pharmacological agents which can preferentially lower the PPG, but it is AGI and glinides are a choice of therapy when we are trying to talk about only post-meal glucose to get control. The American Diabetic Association recommends, even they don't talk about the post-meal glucose so much and they don't talk about the AGI, but they talk that it is clear that postprandial glucose level, like preprandial hyperglycemia, it contributes to elevated A1C level, and its relative contribution is being greater when A1C is closer to 7. So when you are looking at the patient whose A1C is around 8 or 8.5, try to control the post-meal glucose level also along with fasting control. If your fasting is controlled and still the A1C is around 8 or 8.5, try to achieve the tighter control of the glucose also. The RSSDI, we also recommend the same, that post-meal glucose level should be less than 160. It is AGI, GLP1, DPP4, all of them are also working on post-meal glucose level, but glinides and short-acting sulfonylurea are recommended in a patient with CKD who have a post-meal glucose level are high. Now let me talk about this combination where the talk is given to me, what repaglinide and voglibose does. Rapid and short-acting insulinotropic oral hypoglycemic agent, and AGI is a class of agent which is competitive inhibitor of enzyme needed to digest the carbohydrate. In very simple language, this combination takes care of both the parts and they can be combined in a patient who is already the post-meal glucose is not getting controlled. Repaglinide is a glucose dependent. It does not cause so much longer hypoglycemia. It restores early phase of insulin secretion, improves post-meal glycemia, and reduces lipolysis. And it is recommended by various societies, and particularly when PPG is associated with diabetes and CKD, the glinides is a choice of therapy. It exerts direct action on a pancreatic beta cell, but it is unlike sulfonylurea, so the chances of hypoglycemia with glinides are very, very less. It has got an insulinotropic action at a glance, but there are other benefits. It improves beta cell function, it restores early phase insulin secretion, and rapid onset of action with short-lived hypoglycemia effect, and it's a glucose and dose dependent insulinotropic effect. It is other like a glimepiride. It does not cause long acting hypoglycemia, and it is only controlling the post-glucose excursion only. But the point is here, whether it can be given in a patient who is post-PTCA, a 72-year-old guy. Repaglinide is more efficient than controlling the post-meal glucose excursion, and it has got a beneficial effect on reducing cardiovascular risk factor, for which I will show one more paper that. Repaglinide CV safety data. Repaglinide associated with lower cardiovascular risk than any other insulin secretagogue. So if out of all sulfonylurea, if I put, then the glinides, I am not comparing here it with the GLP1 or SGLT2. So mind well, but here out of all the sulfonylurea, if we want to control, the glinides are safe as far as no previous myocardial infarction, those patients, cardiovascular death, or the patient who have MI, stroke, or cardiovascular death. The voglibose, it inhibits absorption of carbohydrates from intestine. The inhibitory activity on maltose and sucrose is 190 to 200 times, 70 times higher than a carbose. It reduces oxidative stress. Voglibose lowers the daily glycemic excursion. It increases the release of GLP1 and had got a better safety profile in compared to other oral hypoglycemic agents. Voglibose prevents post-meal glucose excursion. It reduces post-glucose excursion. It delays distal intestinal absorption and carbohydrates. It also increases the GLP1 level, which helps in delaying the gastric emptying and decrease appetite, and there is a weight loss also. Why repaglinide and voglibose combination can be given? The combination provides better efficacy compared to monotherapy. It is a rationale for doubt in patients who have prandial regulators are needed. AGI modified rapid insulin release, which is induced by repaglinide with different mechanism of action. Both the molecules actually they supplement each other, and there is no evidence of clinically significant pharmacokinetic interaction between glinides and voglibose. If you just see the data that along glinides, if compared to that, if you put the repaglinide and voglibose, there is a significant decrease in the post-meal glucose level. As far as hypoglycemia is concerned, if you combine both instead of only repaglinide, the frequency of hypoglycemia is significantly decreased, because sudden chance of post-meal hypoglycemia will be decreased by adding the voglibose. So the combination have less risk of hypoglycemia and a better control also. So in which condition or useful condition when it can be used? The typical condition is a type 2 diabetic patient with CKD, and definitely the patient with irregular meal pattern, or the patient who have high carbohydrate content, even after explaining the patient or nutrition counseling has been done. To summarize my talk, repaglinide with alpha glucosidase inhibitor, that's voglibose, will provide better efficacy to control post-meal hyperglycemia. Both of them have a different mechanism of action. Therefore, combination will have a synergistic action, and no evidence of clinically significant pharmacokinetic interaction between repaglinide and voglibose. Combination was weight neutral, had fewer hypoglycemia events than in compared to monotherapy. To take away from this complete debate, we all understand that diabetes and cardiovascular disease are both global epidemics, and we have to accept that as a person with diabetes, with the 72-year-old guy, the patient should be given a choice of a therapy which is most CV safe and CV benefit. The post-meal glucose level itself is a problem with the patient with CKD, and it is again higher associated with CV and mortality risk and additional risk factor of hypertension and dyslipidemia. By adding alpha glucosidase inhibitor, we are benefiting the surrogate markers of CVD and maybe useful drug for reducing cardiovascular risk. By reducing postprandial hyperglycemia, by decreasing glycemic excursion, it improves vascular health, reduces oxidative stress, and prevents endothelial dysfunction. It promotes weight loss, it improves blood pressure and decreases risk of hypertension, it inhibits platelet activation, and it improves gut dysbiosis. In real-world data, it demonstrated significant lower risk with the use of AGI and glinides combination for risk of hypoglycemia, particularly in patients of CKD. With this, I thank, but I am sure if patient is referred to us, the patient with the adding the AGI and glinides with the fasting sugar, which is well controlled with insulin, glargine, which is up titrated and getting the even fasting sugar less than 130. If the patient sugar is remaining more than 200, I think it is best choice to add these patients on glinides or AGI combination without increasing the risk of hypoglycemia. If patient is not accepting the GLP1 analog, and which is in most of the situation, a person with a 72-year-old with a history of CKD will not accept the injectable and the costly therapy. So with this, I end my case, but I will be very happy with the discussion. Thank you.
So the house is open for discussion. I think Makar Sahib want to tell something. Makar
Yes,
Sahib.
Makar.
Bankim bhai, would you like to add something? You were.
Marcus
Can you
has
hear
to
me?
unmute, I think. Yes, sir, please.
See, first of all, I would say I enjoyed all the three speakers, extraordinary discussion. And let me tell you one thing, that as the life expectancy has increased, now we see large number of diabetes type 2 patients with multiple morbidities. So it's a case by case dependent issue. See, basically, very difficult to give a guideline for one particular drug in one particular condition, because we come across large number of patients with large number of diseases in a multiple combination. So which drug is to be given, which drug is not to be given, sometimes very, very difficult. But let me tell you very frankly, I entirely agree in this particular given case, because data given are not that complete. What is the dose of metformin? I don't know. So first of all, I would say metformin, according to the eGFR, should be modified. Then you increase the basal insulin. And then GLP1 analog, probably I would give the only factor I would say is cost. That gives me a little bit apprehension whether I should give it or not. And then in that case, I entirely agree with Bansi. Yes, the combination would have been better. But still, I would like to have a drug which is effective on fasting blood sugar. That is the only thing.
Thank you.
But otherwise, as I say, you have to go case by case. That's very important. Thank you.
Mahadev bhai, you would like to add something?
Sure. I think this was a topic of a debate where there was no debate. There's one thing that everybody is talking of science, and we expected more cross corrections or some talwarbaji, but kuch hua nahi hai. Kamal sir, my sorely disappointed, but Kamal physicians are always looking at one side and not looking.
Sir, talwarbaji ke liye aaj sham ko mil rahe hain dinner par.
That's what I'm telling. The physicians are always going by the science and they don't quarrel too much like our counterparts. You know whom we are talking about. But anyway, the point that is not discussed is about the SGLT2 as a whole. But do we have the all SGLT2? We can give it at the eGFR of 30-40. That is what I would ask Dr. Apurva Parekh, who is with us.
Yes, sir.
Yeah.
Yes, Apurva bhai.
Yeah, I think, sir, DAPA and MPA we can give up to 30 only, except one. All the SGLT2 inhibitors can be given near GFR less than 40-30. Even up to 25 DAPA also can be given.
So now the new indication that SGLT2 inhibitor can be initiated even below 30. The latest data is up to 20. It can be continued. Before that, it was there that before below the eGFR of 45, it should not be initiated. But if somebody is already on that, then it can be discontinued up to 30. With the data of DAPA CKD, now it is shown that even the benefit is continued. It is not as in glycemic benefit, but you think of the benefit of CKD progression halt. And that's a much better benefit of SGLT2 inhibitor. So here is the case with the 39, that SGLT2 inhibitor has to be there. It was already there. The patient was already on a metformin, and I'm sure it must be on reduced dose of metformin. Unluckily, I think the fasting plasma glucose return is very high, and that should not be the case. The glargine, if it is already there, the glargine has to be up to the dose when the fasting glucose level should be less than 130 by all means. So a patient with 130, but in patient with CKD, you may see a patient with a post-meal glucose level of more than 250. So you believe that a patient with a more than 250 with a fasting glucose control and still 8.9 or 8.5 A1C. Now, what to do for post-meal glucose to get control? So that was
प्रतिक्रिया देना चाहते हैं.
Yes, Pankaj, please go ahead.
We didn't discuss SGLT2 inhibitors because it was already in another session before. But the point I was willing to raise has been touched by Bansi, that SGLT2 inhibitors, they are excellent drug and they work very well even at GFR less than 30. And the advantages of SGLT2 inhibitors are more in the field of their cardiovascular benefit as well as renal benefits in eGFR below 30. Glycemic benefits goes down below 30, but renal benefits actually goes up. The problem is whenever we are using SGLT2 inhibitors at GFR of less than 30, it can lead to a precipitous drop in blood pressure and may not be tolerated very well by the candidate. So the expertise of a doctor or the doctor should be very high, very good at that level of eGFR to justify its uses over there. Glycemic benefits are lesser at that extent.
सर पंकज भाई आपको तो बंसी ने हिंदी में से इंग्लिश में कन्वर्ट कर दिया बोलने में.
Can I have comment?
Whenever you are
Ashwin bhai, बोलिए. Please, Ashwin bhai.
Yes, yeah. After hearing,
it was very unique to have
Ashwin
Dr. Pankaj Agrawal speak in Hindi. काफी बढ़िया रहा और मुझे यही कहा गया था कि
डॉक्टर अश्विन इज आल्सो
सबसे बड़ा फायदा ये है कि थोड़ा मातृभाषा में भी वार्तालाप होगा और आपकी बातें सुन के काफी बोर हुए, काफी प्रसन्नता हुई और इस तरह का आगे वार्तालाप आपसे सुनने का मिलता रहेगा. आशा के साथ आपको जरूर वापस बुलाना चाहेंगे.
I want to add something. Jashvi, can I have?
Please.
See, looking at all the discussions and looking at the given case, this patient does not require tight control of blood sugar, looking at his age and the conditions.
So 7.5 is required.
I agree with everybody.
8.9 is not the right
control. Secondly, by increasing the doses of glargine insulin, we may invite hypoglycemia at any time because we do not know how is taken. And secondly, his weight may increase with the increasing doses of insulin. So there we have to take extra precautions so as to prevent these problems. Second thing that these type of patients have many times gastroparesis. They cannot tolerate GLP1 so easily. So that required good explanation and to convince the patient that they have to consider like this or that. If I am to treat this patient by doing this, I would have added GLP1 if patient is affording plus AGI, and if not affording, I would have added GLP1a, DPP4 inhibitors plus AGI. Any of these could have give him the better results. But it has been observed that DPP4 inhibitors, they are losing durability after some time. If so, then we may have to think something else. This is what so far I have come across.
But we are very happy that there was a wonderful discussion.
279. Let us understand that this patient is 279 post-meal glucose level, and by adding only alpha glucosidase inhibitor, you will not able to decrease the post-meal glucose by 100 milligram. Here you have to think that you have to keep the target post-meal glucose less than 180. I am not putting the patient should go in hypoglycemia. The fasting I am keeping almost around 110 to 130, and alone AGI will not be effective to decrease from 278.
And even
in given case, now let us understand, if I put the patient on DPP4 and AGI in a combination along with metformin and with the SGLT2, even if you put the DPP4 and AGI also combinedly, you will not able to get this patient. So if I am putting the definitely given situation, it may not be, it's a complete hypothetical situation, but still it will require a short acting, and that's the reason the glinides and the combination of acarbose or voglibose will be real effective to control the post-meal glucose level. And my target for this patient is 110 and 180. We don't want to decrease the A1C less than 7.5. By any condition, patient should not go in hypoglycemia. Then all points are well taken, but still we want to achieve the A1C of less than 8 at least, not 7.5. Patient is referred to us by a nephrologist or cardiologist. Patient himself had come to diabetologist only for getting control. He knows that his cardiovascular safety has already been taken care by Kamal Sharma. His kidney is already taken care by Apurva Parekh. He had come to us only for a glucose control. I don't want my patient to go in hypoglycemia, but at the same time, patient sugar has to be at control. Otherwise, why he has to come for a diabetes specialist? There is no reason for that.
I agree. The whole point of creating this debate was that we need to define not only that the sugar needs to be controlled, but how do you control also matters now, just the way it mattered in cardiology, in hypertension. Now, I think we also know in diabetology, what drugs you will use to control sugar will also matter. We can hear our nephrologist friend. What does he think about the three therapies? Apurva?
I completely agree with Bansi bhai. Completely agree.
I have a question for all the endocrinologists. We change the glargine to either a high potency glargine or a different long acting insulin to control both fasting and PPBS? Oh,
no, sir, I would not do that. I think glargine is a good insulin. I think, there is a lot of noise level from other insulins to say that A is better than B. in my experience, as long as you titrate the patient to, like Dr. Bansi sir said, to an fasting sugar of 110 or 120, you are not inviting hypoglycemia. In fact, this patient would not have hypoglycemia if the basal insulin is titrated effectively. I'm not worried about that. And one thing, I'll say that in my opinion, the newer basal insulins give more of convenience rather than the edge in terms of glycemic control. I think glargine is good enough for as an insulin to control the the fasting sugar, and I think it should be the only thing we need is a good titration here. And that is the main thing we should be doing here. I think Dr. Bansi sir, I don't know if you noticed this. Maybe a few years back, we are having a debate, similar debates.
I know.
I think one of the best thing here is that at least, I would say is that I would consider this as a moral victory, but at least, in this debate, there is no debate about sulfonylurea.
I agree. I totally agree with you, Om. And as Madhav Bhai's comment was on the second generation basal insulin, they are not more potent. Rather than I will also continue with the glargine. And here there is an advantage. This patient is already having 1.7. So, the glargine will also act for more than 24 hours. So there is no reason why you should change the basal insulin just because patient had a creatinine of 1.7. If you are worried of midnight hypoglycemia, if there is a documented hypoglycemia, if you are putting the patient on continuous glucose monitoring and you are finding there is a hypoglycemia, and then you want to change to the newer basal insulin analog, that's fine. Otherwise, glargine is good enough and there is no reason. As he told very rightly that in some of the patients where we use newer insulin are only for the purpose of flexibility because that's for convenience. They don't want to take the insulin at the same time every day. And that's the only reason why we go for the, instead of glargine, maybe glargine 300 or degludec.
One small point I will like to add with the permission of chair is the concern with all insulin is hypoglycemia. The major concern is to rule out midnight hypoglycemia. So in such type of precarious patients where midnight hypoglycemia could be very much deleterious, we can use, and I regularly use, Lantus or glargine insulin in morning hours. I understand that the effect on the fasting hyperglycemia, the hepatic glucose output would be lesser when it is used in morning hours, but it reduces, number one, midnight hypoglycemia chances. Number two, it increases, it gives an edge over the postprandial control as well in the after lunch hours or so. So in all patients at risk of midnight hypoglycemia, this insulin can very well be used in morning hours. It will be safer, and in offering postprandial control, it will become more efficacious as well.
So it was a very wonderful discussion. I think I should make the end of this session, and I'm thankful to all speakers, everyone. आपका भी बहुत अभिनंदन, धन्यवाद. Thank you so much for attending this, and we really enjoyed the whole discussion.